Could you see my PPT? That's good. So let's get started. So these are today's topic: carcinoid tumor, that is NET, neuroendocrine tumor, and then metanephric neoplasm, and then Wilms tumor, aka nephroblastoma, and then AML, angiomyolipoma. So start with the easiest one because this topic not really related to this chapter, but I think just one of the entity here, there is a neuroendocrine tumor from the kidney. The primary neuroendocrine tumor from the kidney is really rare, and then up to 24% of this primary NET arise in horse shoes kidney. Maybe this is related to the birth. And then whenever you see this neuroendocrine tumor in the kidney, you need to rule out metastasis. And then the microscopic uh, feature is really straightforward. We know the cell can forming nest or tuberculate with ribbon-like appearance and then solid sheets. But more characteristic feature is the cytology of the NET cells. So here is this NET cell just forming this ribbon-like structure. They just forming core stick together, and then here they have kind of more solid structure. So the most important thing of this kind of cell is the high power. We can see here is the nucleus feature, salt and pepper. One of the buzzwords other people may use stippling. This chromatin. So the salt is this big chunk of chromatin, and the pepper is this stippling smaller chromatin. And then you can see each of these neuroendocrine tumor cells, they respect each other's border. They don't have any overlap with each other or any nuclear molding with each other. So this feature is really characteristic when you see the next two entity I want to show you. Of course, the IHC marker, we have these two functioning marker. There's the chromogranin and synaptophysin. And then the newest one is INSM1. This is a transcriptional factor. From the literature, it seems INSM1 had better sensitivity than these two. But I think for the traditional, a lot of people still use maybe one of these and one of this. It just depends on your institute. And then the next entity is metanephric adenoma. This is a benign neoplasm composed of small primitive cells resembling early metanephric tubule differentiation. And then BRAF V600E is the characteristic mutation you can find in up to 90% of this entity. And then this is a benign neoplasm, really rare reported metastasis. And in the microscopic, start with low power first. We can see this one is really characteristic. This is normal kidney. And then this bluish area is the tumor. We can see really well circumscribed. And then this tumor cell just forming this tubule, and then with minimum stroma. And then even in the stroma, we can see paucicellular. That means we cannot see a lot of nucleus in the stroma. This is one of the differential feature when you see metanephric adenoma when you try to compare to the Wilms tumor. And then again, these tumor cells try to form this really compact axonite of primitive tubule. And then this is the nucleus feature. We can clearly see this cell is not perfectly round when you compare to the neuroendocrine tumor cells. And then some of the cell kind of little bit nuclear molding with each other, and then they have minimum cytoplasm. And for this kind of tumor, they can have body because maybe before you enter into a pathology residency program, you just heard of the tumor body. You may see kind of other entity like ETC, papillary clear cell carcinoma. You may see small body, and then from the ovarian, you may see small body, and then also from the from the CNS tumor, there's the meningioma, you may see small body. But the truth is that small body, you can easily find it in any papillary structure. So don't let this small body just trick you to think of other entity. So here we just show papillary structure. Here again, we show the papillary structure. And IHD staining, we can use WT1 and then AMACR and CD57. And then if your lab have in-house BRAF V600E mutation immunostaining, that is the really good one for this entity. And then next one is Wilms tumor. I think most of the people, we just call this Wilms tumor, but they have another name, nephroblastoma. So this is a malignant embryonal neoplasm derived from nephrogenic blastoma cell. And if from the broad, I think you may need to remember this kind of syndrome, like 10% is associated with this. And then one of good thing to remember of this entity is 95% of the cases is in children less than 10 years old. And then the peak incidence is 2 and 3 years old. So if you know the history, that will be really good for you to think of this entity. So again, low power, this one different from the metanephric adenoma because we can see the tumor is well circumscribed, but we can see this thick capsule or maybe pseudo capsule. And then this is the normal kidney. And then the classic Wilms tumor, we can see trifasic pattern. That is the stroma, the spindle cell, and then forming any gland, any tubule, that is the epithelioid component. And then we have these plastemal cells. So we have trifasic. But you want to make the diagnosis of Wilms tumor, you don't need to see all of these three patterns at the same time. Like this one here, we just show biphasic, just a plastemal cell, and this forming granular structure, that is the epithelioid component. And then this is the high power for the plastemal cells. You can see again, this cell with very minimum cytoplasm, and then the cell is not round. They have different kind of shape, and then this mitotic figure is really easy to find. And then the cell have nuclear molding. That means the nuclear kind of overlap with each other. And here just show the stroma component can have different kind of differentiation. So they can differentiate it into this skeleton muscle. We can see this eosinophilic cytoplasm, eccentric nuclear, and this stroma component can also differentiate into fat. And one of the things when you write down the report, when you have the Wilms tumor diagnosis, you need to mark down how many percentage of the anaplasia. Why we need to do that? Because it is related, this anaplasia feature is related to the resistance of chemotherapy, and they are related to TP53 mutation. So what is this anaplasia? Anaplasia means we have pleomorphism. Pleomorphism means the nuclear is 3 times larger than the cell adjacent to this cell. So you can see this nucleus is really big, and then some cell is really small, so the size change is more than three times. And then another feature is this nucleus is darker than the other cell, that is the hyperchromasia. And then we can also see this multipolar mitotic figure. So when you see this feature, you need to evaluate the sample to tell the surgeon how many percentage you find is anaplasia. And then the immunostaining is WT1, so you could not use WT1 alone to diagnosis because we know metanephric adenoma, they also WT1 positive. And then usually WT1 positive in the blastomal and the epithelial element, and the stroma usually negative. And these primitive blastomal cells may also label desmin, but not other not other muscle marker like actin, myogenic, MyoD1. And then the epithelioid component may be positive for CK and low molecular weight CK like CK7. And then the last entity is AML. Even from the name, we know angiomyolipoma. So another triphasic tumor. Angio means vessel. Myo, that means muscle. And then lipoma, we all know that is fat cell or adipocytes. And then this AML fall into the PECOma family. Why we use PECOma? Because that is the perivascular epithelial cells. And another thing we need to know that if we can see multiple AML and also bilateral, that means both kidney refined AML, it may be associated with tuberous sclerosis. And then up to 80% of patients of tuberous sclerosis with renal AML. However, when you just find sporadic AML, up to 80% of these AML just sporadic. They are not related to typical sclerosis. So here's the feature I just would like to highlight. We can see the vessel here. I just would like to highlight these perivascular epithelial cells. We can see kind of eosinophilic cytoplasm. And then this cell really like to surround this vessel, so we call perivascular. And then this cell, the cell cytology feature, we can see this bubble-like lipid-rich cytoplasm. Again, here we can show these perivascular epithelial cells. Here, I want to show again perivascular epithelial cell, the fat, and then we have this vessel. So we have these three components. That is the AML classifying. And we know the primary small muscle tumor of the kidney are really rare. So you just see small muscle in the kidney. You need to really carefully to search any adipocyte compartment to just diagnose AML. And then this focal area I just would like to show, we also can see this this epithelial cell show eosinophilic cytoplasm show epithelial feature. That is one of the variant of AML. And then the IOC staining is really characteristic because this cell have melanocytic marker positive. There's the HMB45 and melanate, aka MARCH1. And this cell also stain with smooth muscle marker. We can use SMA, that is the actin, and also H-caldesmin. But the epithelial marker usually negative. So let's see some real slide. Mm, let's stop sharing of my PPT and then could you see this screen, the glass slide? Good. So let's get started. So I will ask some question. Just feel free to answer. If no one answered, I can just go ahead. So for this one, this is low power 2x. What kind of growth pattern will you describe of this lesion? I can tell you we are from the kidney, though I do not have any normal kidney to show here. Anyone have any idea or any description of the growth pattern? So this, sorry, anyone say anything? Oh, okay, let's continue if no one would like to say anything. This is the kind of solid growth. So we can see this nest of cell, this small round blue cell just forming this nest. So, and then we have this tumor kind of really bloody because we can see a lot of like blood vessel, a lot of red blood cells. So the tumor forming this pattern, we first thing really highly suspicious that is the NET, neuroendocrine tumor. So when we just scan all the slides, just everything just grow like this pattern. You didn't see any granular forming, not any tubule. So then you really want to see the nuclear feature of this entity. And then let's go to really high power. Maybe one more high power, not really clear. This is 40x. Yeah, so here we can see really clear each of the cell kind of round, maybe a little oval shape, but they respect each other. Most of them didn't have any nuclear molding. And then we can still see some cytoplasm. And then the characteristic nuclear feature is the salt and pepper. So we can see this truncate chromatin, that's the salt. And then we have this smaller uh, chromatin, that's the pepper. So if tumor have this kind of nuclear feature and then the growth, solid sheets growth, so really high suspicious for the NET. So we just continue to do the immunostaining to confirm like synaptophysin, chromogranin, and INSM1. So I think this one is really easy, but you need to bear in mind you really need to rule out any metastasis from other organ like the lung. So let's move to the other one. So I want to tell you we are in the kidney, but I do not have normal tissue to show. And then again, just low power screen, the whole slide. I think this slide, this one is really the realistic because in the kidney, you rarely see the tumor with that a lot of these adipose cells, fat tissue. So let's focus on this area and talk about this one. I think everyone should know this diagnosis. This is an AML because we can see triphasic uh, angio, that is the vessel, a lot of vessel, and then characteristic vessel of this entity is kind of thickened vessel. So the vessel wall is really thick. So angiomyol, that is this eosinophilic cells, that is our muscle cells. And then lipoma, that's this fat. So we have really good, nice three component of this entity. And then I just would like to show you this is the perivascular epithelioid cells. It's a good one. You can see this is really thickened highlights vessel wall, and then just this eosinophilic with kind of vacuole inside. Sometimes they show really characteristic small muscle cells feature like this gastric nucleus. and then they just try to forming, they try to hugging this vessel. So this is the perivascular epithelioid cells. And then remember characteristic immunostaining, there's the melanocytic marker like HMB45 and MART1, and also smooth muscle acting for the muscle differentiation of these cells. So let's move. So for this slide, we have really nice normal kidney. And then you can see, if I didn't tell you the history, and you may tell this glomeruli should be normal size, but here, because sharing the, the screen, you just see less area of my scope. One of our attending just tell us if you would like to determine whether this glomeruli is from a adult or from a kid or a baby, you can just go to 40x. Normally, this glomeruli will occupy 25% of your 40x high power. If this glomeruli is less than that, it it is properly from the kid or maybe from the baby. So this one I already tried 40x, just 25% of the screen occupied by this glomeruli. So we can know this is from the adult. And then we just go around all the tumor. So one of your impression about this slide is, oh, we can see really well circumscribed lesion, but without any capsule. And then the tumor area, we can see really blue area of the cells, and then some stroma. And then the feature of this stroma is hypocellular. We do not have a lot of nuclear here. So we have minimum stroma, this bluish tumor cell area, deforming kind of this tubule area. And then another area here, we can see this papillary structure. So we know this tumor can form tubule and papillary structure. When you see papillary structure in the kidney, there are three main differential I can think of. Does anyone can think of any differential if you see papillary structure in the kidney? The first, yep, yes, that's great. Yeah, clear cell, but clear cell is so rare. I don't think anyone will think of clear cell carcinoma first, right? So if if you do not know this is an adult, so we should also think of Wilms tumor, nephroblastoma. So when you see papillary structure, these three are the really good differential. Of course, other tumor, maybe neuroendocrine, can have really rare variant to form papillary structure, but we need to always think of some common thing first. So always think of these three common diagnoses when you see the papillary structure. So this one, as you mentioned, there is the metanephric adenoma, because even in low power, we have really good clue. This is an adult patient, well demarcated tumor, and then minimum stroma, and then in the stroma, just paucicellular. So, but you still really would like to see the nuclear feature of this bluish. Again, we look at this stroma, really hypocellular stroma. And this cell, they forming this really compact tubule. And then you can see some nuclear molding, minimum cytoplasm. So that's really good for this entity. And then in in high power, the mitosis is really rare. And then again, as I mentioned before, Silverman body, this lamellae calcification. So whenever when you see this papillary structure, you are easy to find this Silverman body. So let's try another slide. Okay, this one we still have normal kidney. And I can tell you this is the normal size of the glomeruli. So also from an adult. And we can see also well demarcated between the lesion and our normal kidney. And then here we can see papillary structure, really minimum stroma. And then here we can see more tubule forming here. So this is another metanephric adenoma. See another one. Okay, this one I don't think I have normal kidney, but I just tell you well demarcated. And then we can see this minimum stroma compared to this blue cell area. And then this blue cell forming this compact tubule. But this one I just would like to show you one structure, low power. Anyone think of this structure? What's this structure? Looks like, does it look like glomeruli? So I just would like to show you this metanephric tumor can forming this glomeruli structure. Then move on another one. So we have some normal kidney here. And then this one, I want to tell you if you used 40X, and then this normal glomeruli less than 25% of high power view. That's less than 1/4. So this kidney is from my baby, maybe 2 years old. I couldn't remember exactly the history. So we know this is a baby. And then when you see this lesion and normal kidney, we can see this capsule. So this one is uh, really different from the metanephric adenoma. We can see this capsule. And then also this bluish, really primitive area. They forming kind of maybe pseudo rosette or maybe rosette-like structure. And when we screen around, we can see really minimum stroma. But I can show you the stroma. Even in this power, you can see a little bit nuclear there. Let's go to higher power to show you clear. Yeah, you can see this characteristic stroma spindle cell, but really hypercellular. So this the feature when you try to differentiate Wilms tumor and the metanephric adenoma. Metanephric adenoma, if you still can remember the stroma, it's kind of paucicellular. And then also this primitive cell, we call that blastemo cells. And let's go more high power. This primitive cell really dark, really hyperchromasia, and then the nucleus not not like NET. They are not round. They have irregular shape, and then they have overlapping with each other. That is a nuclear molding. And if we go to high power, we can easily find mitotic figure. Even in this power, we can see mitosis. And then some area you can see a lot of mitosis from this entity. And then this one, we just can see these two components. There's the blastomal component and the stromal component. And then we cannot find any epithelioid component from this one. Let's move on. Okay, this one, we also can see really thick capsule. A little bit normal kidney here. And then even in this low power, you just think of papillary structure and then tons of this synovial body. So when we see most of the tumor, this papillary structure, and then we need to think about our three differential, right? Wilms tumor, metanephric adenoma, and the papillary renal cell carcinoma. So when we screen this slide, we can see some stroma kind of more cell. So it may not be metanephric adenoma. And then again, this really small baby glomeruli. So that is also from a baby or infant. So we are thinking of Wilms tumor. So we really need to see the nucleus and then to find our different components. Because of this papillary structure, turns off this small body here. And then we can see the stroma. We have hypercellular. So definitely this is not a metanephric adenoma. And then we can see this kind of cell, they are not spindle shape, but they kind of a little bit nuclear molding, just like this minimum cytoplasm. So they're good for blastomal cells. So and then we can do some immunostaining to prove this is a Wilms tumor. But at least we can find two components. There's the stroma and some blastomal component of this one. So this one, basically, I just would like to show you this papillary structure. Wilms tumor can form mainly papillary structure. So you always need to have this differential in your mind. Another one, this one a little bit different. You can see this well demarcated from the normal kidney and our tumor. And then this time, this glomeruli is kind of bigger. So this is an adult patient. And again, we can see this small body calcification and then papillary structure. So again, we need to have three differential. Let's move around. I think for some senior resident, I think they already noticed what's going on with this tumor. Anyone want to say something? Anything catch your eye, even from this power? Maybe in the screen, you could not see this area really good. You, you may think of definite, this is stroma area. the kind of difference, I can go high power. Maybe higher. Seems the screen is not really good, the resolution. Okay, I think right now you should see something different. We go one high power. I don't want to waste your time to just guess. Okay, I think this power is really good. Yes, for me macrophage. Yeah, papillary RCC. That's absolutely right. So when you see papillary structure and then you go to low power screen, the slide, I think in the microscope, if you bear in mind, you want to try to find these foamy histiocytes or macrophage, you will see it even in 2x. And then you just thinking, oh, this is papillary RCC because this is really characteristic feature of this entity. So anytime when you see papillary structure, try to find this stroma, and then you will know the diagnosis. And then we can take a look at the nuclear feature of this one. Some of the cells just have this eosinophilic cytoplasm, but some of the cells have this clear feature, clear cell cytoplasm. And then the cell lie round, and then they usually do not have high nuclear feature. I know some book, I mean, some GU still like grade this kind of feature, like papillary RCC grade 1, type 1, and type 2. I'm not the GU subspecialty, so I don't know how to use it, whether they still use it or not. But I just know low grade that is the type 1. So, but this slide just would like to tell you the three main differential of papillary structure is really useful. And then you try to look at these foamy histiocytes. And then immunostaining can always helpful because this entity CK7 positive ACR. Then show you one more. This is the same diagnosis, but from different patient. Even in this 4x power, when you think of foamy histiocytes, you may think of, oh, maybe this is foamy histiocyte, and then you will go to high power, and then you can find a lipid inside this stroma, papillary structure, and then you will think of papillary RCC. This one I don't need to go to high power. And then I have two really interesting one I share in our WeChat group. Some people may have seen it, but the history is really interesting. Again, just low power screen of the slide. Here's some normal kidney, tons of fat, vessel, and some unknown things. Some people may know, some people maybe the first time they see this kind of thing. But if you are interested in derm path, you will see this quite often compared to other subspecialty. Okay, let's focus on this area first. So anyone know what it is? There's some weird material. I say this is a material. And then what is this structure? This circle structure. Yeah, this embolization material. Do you know what kind of material? Any idea? This is the gel foam. If you're interested in derm path, you see this because some surgeon will use gel foam when they do shave biopsy, maybe some punch biopsy. If bleeding, they will use this kind of material to try to uh, stop the bleeding. But this time, I think the intervention physician just used gel foam to embolize this tumor because of bleeding. And then from the history, this patient had kidney transplantation. So do you have any guess of the history of this patient? Why this patient, after they take out this tumor, why this patient need to get a kidney transplantation? Any thought of the history you want to say? When the patient get kidney transplantation, that means two kidney didn't work, right? So I would like to tell you both of the kidney have the same kind of tumor. And then this patient bleeding to death. So the physician need to embolize both of these kidney. That's the reason patient get this gel foam in the vessel and then take out the kidney, get the kidney transplantation. So go back to the diagnosis of this case. This is a really good area. I think everyone can guess the diagnosis because there's limited entity of today's lecture. So we have this muscle, fat, and then web cell. So this is another AML, angiomyolipoma. So we also can see this bubbly perivascular epithelioid cell try to hugging the web cell. The reason I would like to say this coma again and again because I want you to familiar with this term, perivascular epithelioid cells. So this is the AML. This patient had a bilateral AML. So this patient have tuberous sclerosis. So the whole story of this patient is really in, interesting, especially when you didn't know the history and then you just see this gel foam here, and then your diagnosis of AML, and then you can guess the whole history of this patient. So I have the last case. To low power. This one is different from all the slide I showed you before. Really catch your eye is this nest sheath growth of this cell with eosinophilic cytoplasm. And this is the normal kidney. It seems this tumor may have a capsule, but I'm not sure. But one feature, even in low power, there is this thickening, dilated blood vessel. It is really helpful when you think of the differential. Let me show one area, maybe try to treat you a little bit to high power. Okay, if all the cells just look like this area, I think you will have one differential is why not this is not clear cell renal cell carcinoma because really clear cytoplasm here. And then all the cells just look like this. You may think of clear cell renal cell carcinoma, but one of the feature didn't fit. What feature could you think of? Yes, we have minimum blood vessel here. So even if it is RCC, you will really doubt yourself whether it is true RCC. And then another feature is that usually RCC, the cell did not look this high grade because even in this uh, area, we can see some maybe have nuclear oli, and then some cells show polymorphism. Some cells are smaller, some cells bigger. So for a renal RCC, it should be really high grade renal cell RCC. So when you think of polymorphism of the tumor cell in the kidney, some diagnosis we need to put into a differential. RCC should be one, but we need to see really high grade. The other one is chromophil RCC. There's another one you may see really high grade nuclear feature. And then the last one is this entity. So let's try to find some area. Yeah, you can see the cell really polymorphic. But this cell also show this like vacuole structure in the cytoplasm, but not like clear cell. The cytoplasm is not totally clear. And then we can see some kind of cytoplasmic like this. If you do bone and soft tissue, you may think of, oh, it's really look like one burst word for the rhabdomyoma. There's the spider cells, something like a spider. They have some leg to just connect to this uh, cell membrane, something like this. And then this cell feature, we would say epithelioid feature of these cells. Yeah, here we can see the vessel. This kind of dilated, maybe if I better one. You can see the cell really polymorphic here. It's really rare to see renal cell RCC have this kind of polymorphic nuclear feature. Yeah, this vessel is thickening, and then they have some kind of cell try to hugging around this bubbly cell with this clear cytoplasm, especially like this one. So this is perivascular epithelial cells. So this is AML, but epithelioid variant. We call that epithelioid PECOma or epithelioid angiomyolipoma. So when you see high grade feature and then the cell growth like nest, solid growth, epithelioid cell, you need to think of renal cell, a clear renal cell carcinoma, chromophil renal cell carcinoma, and this epithelioid AML. So I think that's all I have for today. Any other question? Any comment? Mm-hmm. Blastemo. Yeah. Blastema, that means primitive cells. This cell with really dark nuclear feature, nuclear molding, irregular shape, and really high grade uh, nuclear feature. That is the blastemo cell. I think just Will's tumor will use this blastemo cell to mention, kind of like a buzzword. When you say blastemo cell, other people will know you are talking about nephroblastoma, aka Will's tumor. Because if we have other like this primitive neural differentiation or any kind of this primitive cell, like neuroblastoma, we didn't use blastemo cell for the neuroblastoma because we use neuroblast for this kind of cell looks really similar. Yeah, very good question. Any other question or comment, or we can just stop here and everyone have a good